Hello to those who are here in the webinar on gender-neutral vaccination for human papillomavirus. You see me here together with my friend and colleague, Dr. Claire Somerville. And the two of us, we want to have a dialogue, but we don't want the dialogue to be only between the two of us. We really want you all to participate and perhaps even share stories. So my first and most important thing to you is keep your questions and your stories. You can either put your question or stories in the chat function that you see below, or you can also ask to be online with us if you have something which you would like to share with everyone and if you are fine with becoming visible. So this is my first and most important householding rule. Be with us, be in a dialogue, and ask the questions. But we will start, we will start and talk a little bit between Claire and myself. But we have foreseen 3 parts. The first part is a kind of introduction about viruses, men and women, interesting stories, by the way. And there we will stop and ask you already have your questions. And then we will go for a second small part about early detection and screening of human papillomaviruses. Again, we will have a stop and ask you for questions. And then the last part will be on vaccination. And after this last part, we will have a real broad discussion. So if there are questions left at the end, it's all your time. As a whole, we have 2 hours, so I hope we will be really able to come into a very, very vivid discussion. So now let's start. My name is Bettina Borisch. I'm a professor at the University of Geneva, Institute of Global Health, but I'm also a histopathologist. That's why you will see some pictures. And and that's my function here, I'm the executive director of the World Federation of Public Health Associations. And I hand over to my friend and colleague, Dr. Claire Somerville. She is in an institute very close to ours. Claire, who are you? What are you doing?
Hi, Bettina, and hello to everybody online. My name is Claire Somerville. I'm a medical anthropologist. I'm at the Geneva Graduate Institute, where I'm the executive director of the Gender Centre. And my area of research is really bringing a gendered perspective or looking at gendered ideas and lenses on all global health issues. So I'm hoping to offer you a few insights today on HPV. Thank you, Bettina. Back to you.
Yes, so let's go for the story of 2 sides of a coin. You see us both here. One looks with the public health epidemiology pathology, and one looks with a gender lens. And we hope to be able, with the 2 different views, to give you a better understanding of why we think vaccination for human papillomavirus should be done with girls and boys, and not only girls. So I start in the introduction with the virus, and that's already wrong because it's not the human papillomavirus, but it is several human papillomaviruses. There are over 200 different types, and every time our colleagues in the labs continue to work, they discover new strains. Among all these strains of the different human papillomaviruses, 40 of them affect the genital area, but most of them don't pose a serious risk to our health. And one single person, can be infected with more than 1 HPV strain at the time. Now, these little viruses, here you have one, all viruses, not only human papillomaviruses, you know, they cannot live on their own. They need cells, human cells or animal cells, or even plant cells to survive. So they use our cells for their survival. Some viruses are quite specialized, what the cells are they use, and so are human papillomaviruses. They need epithelial cells for their survival. They grow within epithelial cells, and epithelial cells do what we say differentiate. So they change during their growth. Where do we have epithelial cells? Very funny term. Where do they sit? Well, they're easy to access because epithelial tissues line the outer surfaces of organs, inner surfaces, and also outside of our body, the epidermis, the outermost layer of our skin. So if human papillomaviruses want to access their preferred cells, they have an easy way to go. They don't need to go into some blood cells like the AIDS virus, far more difficult to reach. They come on our surface, on our linings, in different places. Now, as I said, epithelial cells have a turnover, and they have a fast turnover, so they differentiate. When they start to be in life, they are small, and they grow and become different things. You know that hairs and nails are parts of our epidermis, for example, and you know how fast the hair grows, do you? That's how hairdressers earn their life, you know. And epithelial cells change while they're growing. And it's important that they always divide because a lot of them died. Not only our hair cut away, but also our outer dermis goes away when we take a shower every morning. So that's a perfect setting for human papillomaviruses. They use these easy access cells, and they use the growing and differentiating system of these cells for their own replication. So kind of they are helped by our system. They hijack our epithelial cell system. And here we look at them, at cells, I said I'm histopathologist. What you see here is single cells. It's not in a cell tissue, but single cells. And these single cells are stained. So when you see this cell here, it's a quite normal cell with a small nucleus and pinky, nice pink. If you look at this one here, it looks different. It's blue and has a dark nucleus, big one. Why is the nucleus big? Because the virus sits there and uses the replication system. And that's why the cell nucleus is far larger. So what we see here is cells taken from the cervix of a woman. And you can say that, yes, there are normal cells, and there are cells that must contain a virus, and they have changed completely their shape, and they look not the same as the normal cell. So no panic, because this cell looks ugly. It is not yet a cancer cell. And most people with HPV have no symptoms and feel fine. So they usually don't even know if they are infected. And the genital HPV infections, because with the picture we were in the cervix, they are not harmful at all, and they go away on their own. How and why? Because our immune system can clear the virus by itself if there are not several reinfections all the time. So many HPV human papillomavirus infections cause no symptoms, and 90% of them resolve spontaneously within 2 years. But what are the changes that the human papillomavirus can do if it stays long and long enough? all the lesions the human papillomaviruses do are located in epithelial cells, inner or outer lining cells of our body, as we have seen. And there are some malignant lesions, cancers as we call them. Malignant lesions of epithelial cells are cancers. And where are they found? Well, in linings. So parts where there is a lining, that the very well known is the cancer of the cervix or the vulva or the vagina, but also the penis, anus, mouth, tonsils, or the throat. All these parts of the body are lined by an epithelium that can take up human papillomaviruses. And if they stay in long enough and can replicate long enough, they can change the cells in a way that they become cancers. But these human papillomaviruses, as I said, there are very different types and strains, and some of them make what we call benign lesions. I think every one of you knows what a wart is. Warts are very frequently found on sole of foot and on the plantar side of your hand, but also in other places, like on the penis, for example. Warts are unpleasant, difficult to get rid of, very difficult to get rid of, but they will never grow into cancers. So that's why we call them benign. But the human papillomaviruses are behind the lesion. So I said different parts do different types of human papillomavirus, do different things. So we have what we call high-risk human papillomaviruses. They cause several types of cancers. And because there are so many human papillomaviruses, we couldn't find names for them, so we gave them numbers. And that's a little bit awkward because you have to keep in mind what numbers. And the 12 high-risk types are the 16, 18, and the 13, 31, 33, 34, 39, and then some in the 40 and 50s. The other ones, 6 and 11, are the ones for genital warts. So 6 and 11, if you hear that, they are the benign ones. And out of the high-risk ones, HPV 16 and 18 are responsible for most human papilloma virus-related cancers, including those involving cervix, vagina, vulva, penis, and anus. Now, this is, I think, knowledge that has been quite well distributed among women, especially if they go for cancer screening. They heard about that. But what should men need to know about human papillomavirus? If a man carries or is exposed to a human papillomavirus, even to a high-risk one, he's unlikely to have symptoms. And if there are no symptoms, it is very hard to test because we don't have tests. But it's important to know that more than 90% of anal cancers are linked to HPV infection, and most penile cancers and mouth and throat cancers are also associated with HPV infections. So I think it is really time to say men need to be concerned about human papillomavirus, because all the cancerogenic types can be passed on through genital or oral sexual contact, and HPV can infect men's genital areas, including the skin on and around the penis or anus, as well as mouth and throat. So that's why I turned to my friend Claire and asked, what about health in men and boys, and why is it so different? You know so much more about men than I do. Please, Claire, explain me.
Thank you, Bettina. So first of all, patterns of disease and patterns of access to healthcare do vary, and they vary along many different axes, including men and women, boys and girls. They also vary, of course, according to age, to ethnicity, to geography, social economic status and place. But we're going to focus just today on the health of men and boys. So what's quite interesting in disease patterns generally is that males live much less, shorter lives than women in all countries. This isn't particularly well understood, but it's certainly more than to do with biology. Two distinguishing features of this is that men have a much higher prevalence of diseases that are sometimes quiet diseases. They're symptomless, they're not obvious, but they're diseases that can impact life expectancy. Typically, we think about cardiology, cardiac diseases, which are fairly quiet for a long time, a little bit like the HPV you just described. The other thing is that men in most countries suffer from less physical functioning diseases. We tend to see rates of arthritis and those kinds of diseases higher in women. So it's often said that whilst women live longer, they live in worse health than men. So some of the reasons behind that, some of it's to do, historically at least, with war and conflict. Men died in war and conflict. In terms of occupations, there are typical gendered occupations that lend themselves to higher risks and higher dangers. Associated with that also is risk-taking behaviours. We sometimes think about these in terms of the causal factors behind things like heart disease. Rates of alcohol consumption and smoking are typically higher, not always, typically higher in men than they are in women. We also know there are different patterns of access to health services, and these are often related, and this is related to HPV and reproductive health, often related to the life cycles of men and women's engagement with the health system, particularly women who give birth or women who become mothers. Their engagement is different typically from those of men. So we have a series of reasons as to why we have differences. That's just a very sort of a small sort of snippet of information. So it's more than just biology. Can we go to the next slide, please, Bettina?
Yeah.
Thank you. So let's now think specifically about HPV and the health of men and boys. What we have are a few challenges, and I put these into two sort of categories. One is around knowledge and awareness. We know that engaging men and boys in health and particularly in health related to these types of issues can be challenging. And in particular because these are associated with the reproductive system, typically when we think about cervical cancer, and a physical contact. And these can be the areas where there is some sort of sense of taboo and difficulty in discussion. We also know that we socialize our boys and girls differently to access health systems. Girls at the age of puberty may well start to engage with health systems and have a different set of knowledge because of their menstrual cycles. So our approaches to boys and girls typically are a little bit different in terms of their knowledge and awareness in those early years when we would want to be thinking about HPV. There's some of the explanations. We have a concept in gender studies and gender and health of masculinities. This is something that is different everywhere in every context. But these are some of the stereotypical behaviors. So some, for example, might be that we know from surveys in all countries that men typically, not always, seek treatment a little later than women. Women typically tend to seek treatment earlier and engage in a lot of preventative activity, whereas men typically wait until they've had the heart attack before going to seek treatment. So we know we have a different role of prevention in men and women, boys and girls. We also know that there's a lot of stigma associated with these kinds of HPV virus infections. And these can also be what we say as gendered in a sense. There is also, Bettina, I think, a sense that HPV is highly feminized. It has really become an issue about women only. And I think you probably agree with me that we need to sort of work on that a little bit, because it's really not just about women, and the problem, the challenge of it being so feminized was we're possibly excluding men and boys for the important contribution that they can make to HPV prevention and cancer prevention. So just the next slide, very briefly. Thank you. So just from my sort of gender perspective, all of these things that I have talked to you about are what we describe as the gendered determinants of health. So when we move beyond the biology and we look at all the other factors in society, about the roles we play in society, the gender division of labour, our roles in the household, at the home, at school, the way we socialise men and women, boys and girls differently. And also decision making, and particularly when we're talking about children, decision making on access to care and at what point different preventative activities are appropriate for our children. So decision making in the household can be a gendered decision. So all of these have an impact on how we engage men and boys, women and girls, families, communities, and also the health systems in the way that we respond to HPV. Thank you, Bettina. Back to you.
Yeah, thank you. Before we go to the second part, I would like to ask if there's someone who would directly to ask questions. I have seen someone who is in the chat who's called Spectateur Anonyme, but is there someone who wants to come in live and ask us questions to this introduction part, which is the starting point for our discussion? For Spectateur Anonyme, he comes with broad questions that are probably best discussed at the end. It's about the UK government, and then the question about high and low income countries and vaccination. That's, I think, if fine with you, Spectateur Anonyme, we will put it to the end when we have talked about vaccination, if fine with you. But are there any other questions or someone who would like to come in? Please let us know. I don't see. I hope that you will come in for Spectateur Anonyme. I like your first question because you ask, why do you think the regressive UK government only advocates the vaccination for women? I have tried to get this as a 36-year-old man, and it's hard to find and very expensive. Do you think this will change with the change of government? Wow, I'm not into the UK politics, but I know that the decision on broadening the vaccination programs from girls, women only to men is a political decision mainly. So it will depend on your political leadership that you will have very soon, probably renewed. That would be my answer. And if fine with you, Spectateur Anonyme, I will take up your second question when we have talked about high and low income countries. Anyone who would like to come in? No, nothing. So we talk too much. Then I'll continue with the fact that the good thing about human papillomavirus associated lesions is that the human papillomavirus takes long time to make the cells that I have shown you to become real cancerous cells. It takes 15 to 20 years for cervical cancer cells to become cancer after the infection. And that makes it possible to see the early changes and the precancers, because there are precancers that you can see under the microscope, but they don't make symptoms. So we have to screen and to look for them, how much the cells have already changed, how much they look more like a cancer cell, more blue than pink. So yes, there is a lot of screening going on for HPV-associated lesions. in countries with healthcare systems. And that means that in these countries, we had a screening program. This is a pap smear. If you hear the word pap, it comes from the Greek name Papanikolaou, a Greek pathologist, cytopathologist, who before we knew about human papillomavirus said we have to do something. Cervical cancer is so frequent. And he knew that the epithelial cells where the cervical cancer grows are very accessible. So he introduced what we call the pap smear. So with a little brush, you take out some cells and you make a cervical cytology. You look at how the cells of the cervix look like. And he also introduced these nice pink-blue scarlet. And though was it done for a long time, we looked at how the cell changes are. And when the cell changes are too weird, too close to a cancer, we said here we need to intervene by measures like excision of the cervix or something like that. Later on, we discovered that human papillomavirus and its subtypes are involved. And now the screening became easier even because we could look for the virus itself, just look for the virus. And so a screening system was put up, and you see that's its program is a long thing. You invite women to come, they can take a smear or take them themselves. We look at the virus first. If there is no virus, then we say everything fine. If there are HPV viruses, then we look at the cells. If the cells look fine, low grade, as we say, no worries, just follow up with normal screening. But if they have high lesions, as we say, high-risk lesions, then we have to refer to hospital and see further if something needs to be done. If you see all this, this needs a fully developed healthcare system with referral points, labs, lab technicians, cytologists, microscopes, you know, all this, invite, second look at, and so forth. In a lot of countries, this is not the case. So the pap test and the pap smear couldn't be done. And a little bit trying to replace it was to just look into the cervix and color the cervix with a color that is called Lugol's iodine, and it shows the suspicious epithelial cells. That's what was tried to do, but still you need to have to go and see a gynecologist. Whereas if you only do your same own sampling and send it to a lab, it's easier. We have seen that the self-sampling went well with asking women to not go to a gynecologist or someone, because there are also barriers and you may not have a lot of gynecologists around or no time. But if you sample yourself, your cells in the cervix, then it has been shown that women are able to do it as professional, I would say, as a doctor, and that you have the same results if you then test for HPV. That has happened during COVID, where a lot of women couldn't go for their normal pap smear. So they sampled themselves, sent it into a lab, and the lab said there is HPV, and then only they went. So screening for other HPV lesions. I have talked about the screening programs for women only. There is oral cancer, which is a very serious, broad, major public health problem in a lot of countries, especially in Asia. And it affects both men and women, and now more and more young women. And unfortunately, even if the mouth is very accessible, many patients present with late-stage disease, and that gives a high mortality to this kind of cancer. And we see that oral cancer years ago was seen as a cancer of the old man who smoked a pipe and drank a lot of alcohol. It's no longer the case. We see that more HPV-associated cancers occur at age range that goes to younger individuals. Unfortunately, something like the screening for cervix cancer, a population-based screening program, exists almost nowhere. I know that there has been a pilot study in Kerala, one state in India, and it has proven to be useful. And the only country I know where there is an oral cancer screening program is the island of Taiwan. But anywhere else, nobody screens or tests for HPV, and it would be easy of access. So screening for men's HPV, there is no test like the pap smear for women. There is no screening test for men's HPV. And so there are no screening programs for men. But in the future, I think we have to consider the possibility for such screening. They are there because, as I told at the beginning, epithelial cells are at the outer linings of our body, so they are accessible, and we could take samples of cells from the anus, from the oral cavity, but also from the penis, for example. Before I go over, I would say I saw that there is a third question in. We will come to Scott Anthony Martin, because it's definitely a question to my friend Claire. But first, I will hand over to Claire, because you could say something more about HPV prevention, early detection, and in men and boys. So please, over to you, Claire. What do you think about all these screening and early detection measures?
Absolutely. Thank you, Bettina. I think that there's a challenge with all of those early detection methods in men is that they require quite a sophisticated system. I mean, you described very nicely the system for pap smears, but you see how complex it is and how many different actors are involved, from someone to take the smear and testing facilities and so forth, and communications to send results back. So whilst there isn't an HPV, but there are some types of screening tests that are available. Developing a complex system to deliver on those for men requires a lot of investment. So I think, again, the challenges of this health system are very prevalent, and with HPV being such a feminized disease and the sectors where it is dealt with being highly feminized, it is unlikely, I think, that these will be in a position to offer these types of screening tests as much as we would love them to be there. So one of the things I think of, and again, it does need quite a well-resourced health system, but having men's clinics, and I think men's health clinics are something that are coming to fruition in different places. And the sorts of things we think about are the designs of the clinics, the hours that they're open, who are the people who are facilitating, who are the doctors there. So there are certain ways that we can make it the engagement of men and boys in preventative activities have a higher take up. There are different things we can do. Again, I think education and awareness building is really important, but I also think in terms of those societal structures, we're talking about issues of sexuality, which also play into our legal systems and judicial systems and cultures and customs, in the sense of what is the age of consent, what are marriage rules, what are same-sex relationship legal systems, and all of those. So it's a very complex, not just about the system, but a very complex societal issue to engage in these types of screenings that you have described earlier for men. But what I really want to sort of land on here is I actually think we can be quite positive about this. I think we can develop systems and we can overcome some of the societal challenges by engaging what I describe as a gender positive approach to HPV. I know it's in the literature is often called a gender neutral But I prefer to say that we can actually do something rather more challenging and positive, and calling it a gender positive approach to HPV, in where we actively engage men and boys and communities in the prevention of HPV infections. Thank you, Bettina. Back to you.
Yeah, thank you so much, Claire. I see that there is a question that I would really take to you, coming in from Scott Anthony Martin. I'll read it out to you. How can we overcome some of the gender-specific reasons behind why boys, men, do not seek medical care, especially in the context of HPV, which takes longer to show, if at all, in men? What would you say to Scott Anthony Martin? Claire.
Thank you, Bettina. Thank you, Scott, for this question. I mean, absolutely. I think it's about socializing young, and from my gender perspective, I might also add that having comprehensive sexuality education in schools and in communities and in our health systems might also help engage men and boys, or particularly young boys, into understanding more about HPV and thinking about their roles and that they play in transmission later in their lives. So I think it'll also be part of a more general health package and approach to boys, and socializing them into caring about themselves, self-care, and engaging in health systems. So very much an educational and awareness approach that also seeks to engage young boys. And I think that's where we really need to be working. Self-care.
You think we should start with the young man, the youngest man?
Absolutely. I think we typically do that with girls. We're less good at doing that with engaging boys early on in self-care and health.
Yes. And you also mentioned the biological difference, saying that yes, girls have their periods and they have a menstrual cycle. So in fact, they are pushed to a more body and health attitude. What could we do for the boys?
Absolutely. But I think, in terms of comprehensive sexuality education, this really does engage boys and girls in similar and different ways according to the changes that they're going through at different stages of puberty. And that boys also have a role to play, an important, very important role to play in the prevention of all diseases, not just cancer, HPV-related cancers, but also as part of the whole socialization process, that we can engage and actively engage boys in these types of preventative activities. I don't think it's impossible.
So that's very good news. And again, before we go to the topic of vaccination, please ask the questions you would like to ask. And also, you can raise your hand if you want to be online with us and ask your question or share your story for the different stories that helped, or you, or what happened to you. Really, we're very much open to this. Now, I saw someone shared a resource with us. We will have a look at that also. Thank you very much. I think that in our third part, we will talk about the vaccination. And the vaccination only became possible because we understood, due to work of Harald Sohausen and his wife. He got the Nobel Prize, not his wife. Short little gendered aspect into the human papillomaviruses and their link to cervical cancer and other cancers. Because we knew the virus, a vaccine could be, or several vaccines could be developed. And nowadays there are several vaccines on the market. So in fact, we are in a situation that is a little bit like the polio. We could be able to eradicate, but we are far from that. So the vaccine. What does the vaccine, the anti-HPV vaccine, do? In fact, the vaccine protects against genital warts and most cases of cervical cancer. It protects against cancer of all the places like vagina, vulva, penis. And that's a very important thing. We have a vaccine preventable cancer. This is not very frequent. We do have other cancers that are associated with viruses, but we have not yet had a situation where we can prevent. And for HPV, it's the case. And the thing is, because HPV high-risk strains go for mouth, throat, head, and neck cancers, we know that the vaccine also gives protection against these cancers in other sites where there are epithelial cells. So how does these vaccines work? Well, we have now already a little possibility of a follow-up and follow-up studies that go over 10 years, even longer. We can say that HPV vaccination works extremely well. The vaccine has the potential to prevent more than 90% of the HPV-linked cancers, which is a very good news. And the first recommendations were from 2006. So you see the time to introduce vaccination programs, to introduce the vaccination. Let's say we have a follow-up now of over 10 years with studies. We can say that infections with HPV types that cause cancers and genital warts have dropped by 88% among teen girls and 81% among young adult women, because these were in the initial screening programs and vaccination programs, the first ones to get vaccinated. And another good thing about the vaccine is that you know that some vaccines, you have to repeat them on a regular basis, and you should repeat them on a regular basis, like your tetanus protection, for example. But we see that the protection provided by HPV vaccines lasts long time. What has been done, given the new introduction, people who received HPV vaccines were followed for at least 12 years, some longer, and their protection against HPV has remained high with no evidence of decreasing. So that means that probably this is a vaccine that stays as a protection for a quite a long time. As I said, we have been introducing screening programs and vaccination. No, we have been introducing vaccination programs only from the early 2000 years on, so we are still having studies ongoing and learning. Now, who should be vaccinated? And here comes the question where we are discussing who should be vaccinated. We say, and here I say children, I don't say boys and girls, we say children ages 11 to 12 should go get 2 doses. Now we are changing somewhere into the single dose vaccination, but at the beginning of vaccination programs, got 2 doses in a period of 6 to 12 months apart. And why this age? Because HPV vaccines can be given or should be given before sexual activity. And it was thought that this is the age before uptake of sexual activity. If you vaccinate later on, and anyway, we are now going for single dose, people under the age of 25 will need just 1 dose of the vaccine. Now you may be frequently asked by people, adults above 25, should I be vaccinated? And the question comes up for adults between 25 and 45 years who have never got a vaccine, because at that time there was no vaccination program, there was no vaccine on the market. They may decide to get an HPV vaccine after discussing with their doctor, especially about their special risk for a new infection. It depends very much from your lifestyle, the way you are behaving, and it is a real individual personal decision together with your doctor, but you can get it, and it will be a certain type of prevention and help. But HPV vaccination in this age range, so at adults, provides less benefit because most of the people, or more people in this age range, have already been exposed to one or the other strains of HPV by then. Nevertheless, it can be useful to take up the vaccine. But, and that's the thing about why we are here together today, the question, who should be vaccinated, is in a lot of countries, only girls are vaccinated, and is still like that. Before we enter the discussion why one country says only boys, why the other one says only girls, and the others do both boys and girls, let me tell you a story. I'm not sure if you know the lady that I show you on this picture. It looks a little bit
Don't cry for me, Argentina. The truth is I never left you. All through my wild days, my mad existence, I kept my promise. Don't keep your distance.
I think you know the person. Or is anyone knowing Evita Peron? Evita Peron is the lady you have seen in the picture, and the little bit of the film I showed you is the film Evita on her life, and she was presented by Madonna. She sang "Don't Cry for Me, Argentina." Why do I show you this Evita story? I don't know if every one of you is aware of the fact that Evita Peron died at age 34 already of cervical cancer. At that time, oncologists didn't tell their patients what they had because they considered it's too difficult for them to bear. So Evita didn't know. She knew there's something really weird. She was sent to the US, from Argentina to US, to be operated, but everything was too late. She died. This is very, very sad to Evita, but I'm telling the second part of the story that is less well known. Less well known, Mr. Peron married for a second time. And his wife, his second wife, died also early of cervical cancer. What does this story tell us? The story tells us, first of all, cervical cancer kills women at a young age. Second, we learned that cervical cancer is probably a transmittable disease and that men are a reservoir. We could conclude, we have no tests, but we could conclude that Mr. Peron was a carrier of HPV strains and of carcinogenic HPV strains. So I think this story tells us a lot about the link of HPV to men and women, and to the serious impact that this can have. You know that Evita was a hero in her country, and she contributed a lot to her husband's success in politics. So this story being told, I would like to come to the question, why should girls and boys be vaccinated? And I start with the arguments in favor of gender neutral, or as Claire says, gender positive vaccination. I think there are many arguments for the vaccination of both sexes, and here they are. First of all, boys and girls can get HPV-associated lesions, both benign ones and malignant ones. Both can get cancers that are HPV linked. Then is the question of transmission. We have to consider human papillomavirus as an infectious disease, and the most common way of transmission is by boy-girl contact, by sexual contacts, or very close epithelial contacts, skin and others. Different forms of sexual contacts are a way of transmitting HPV. And as we have seen with the story of Evita Peron, men are also a reservoir for human papillomavirus. They are, even if not knowing, transmitting HPV. And if I put on my head as an epidemiologist, then I would say it is absolutely incredible to just vaccinate half of the population, because the most and the best functioning vaccination program is trying to cover the whole population. And this is not well done if you have only half of the population. And the eradication, that's what we know from studies, gets much faster if we cover both boys and girls. There have been studies done in the northern countries that show clearly that the eradication of HPV goes faster if you vaccinate both girls and boys. So from my biology point of view, but also from my epidemiology point of view, I would always say, let us go and do a vaccination of boys and girls. Now, there are clear arguments to say only girls, and I show the statistics of the incidence of cervical cancer, and it is a dramatic picture that you see here. The incidence of cervical cancer is much higher in Southern Africa, Middle Africa, Central America, the Caribbean, than it is in New Zealand, North America, Europe. It is a sometimes tenfold higher incidence rate. And again, also mortality is much higher in some continents than in others, in some places than in others. This is an inequity that is terrible, that is unacceptable. And why is it so? It is simply not possible to do in a lot of these countries, the screening programs that I've been talking to, and there is very little possibility to do so. But these countries can have vaccination. You will never build up, I think, cytology labs and all this for screening, but a vaccination should be possible. So I think if we look at these statistics, we have an ethical and human ask to do something in the places where HPV-associated cervical cancer is still a very, very important public health problem. And if I go to a country like mine, like Switzerland, it's not really the squamous cell carcinoma, as we call it, of the cervical cancer is infrequent. It's only 1 to 2 per 100,000. And we have only 230 new cases in Switzerland per year. If you compare it to the other female cancer, breast cancer, we do have 5,250 new cancer cases. And I think this is nothing compared to countries where cervical cancer is the second most cause of death for women. And we know that cervical cancer affects more than 500,000 women each year and disproportionately impacts women in low and middle income countries, where nearly 9 in 10 deaths due to cervical cancer occur. Let us just look at these terrible figures. In India, the incidence is 22, so 20 times more than in Switzerland. The mortality in Nigeria is high, very high, if we compare it to countries like Switzerland. So I understand that in low-income countries that are resource restricted, they try to get the little bit of resources for a vaccination campaign to girls. Given the risk of cervical cancer and the high mortality of this cancer in these countries, girls are chosen over boys. That's also the attitude for the moment of WHO. And again, I'll go back to Claire, we heard about that. There is the region that traditionally it's easier, there is an easier uptake of vaccination by girls and women. And what we should discuss very soon, and I see the questions are coming up in the Q&R, we should talk about money. Is the money the main argument in this? But I would like for here to thank you for listening, and I hope we can go now to the questions and the questions that already piled up. But also I would like to perhaps ask people if they want to come in. I see Dr. Navid has asked a question. Would you like to be on screen? And then raise your voice, please, Dr. Navid. You just have to raise your hand in the raise hand function. Otherwise, I'm going. Yeah?
Yeah, can you hear me?
Yeah, there you are. Please speak up.
Thank you. Thank you very much for the very detailed presentation. I just want to ask about the adverse effect following immunization. Do you have any evidence in the countries where it's been already in progress, the vaccination of the HPV vaccine? And what about the outcome of case investigation? Thank you.
Sorry if I got it right. You asked for experiences of countries that already have a vaccination program for a long time, right?
No, I am talking about AEFIs, adverse effect following immunization, regarding HPV vaccine.
Sorry, I couldn't get your.
Actually, I have already typed the question.
Yes, you have typed it in. Yes, you have said in your question, what is the evidence of AE AEFI regarding HPV vaccination, right?
Yeah, exactly.
So the adverse events following immunization with the available vaccines, because that's your main question, are very little. I mean, directly after the vaccination, there can be a pain in the arm. There can be a little feeling of fever, but more than that, there haven't been reports of serious adverse events following this kind of vaccination. We always have to say that the vaccines came into vaccination campaigns only at the late 2000er years. So we are still collecting knowledge, and we will have knowledge as soon as broader vaccination campaigns are running. But what has been shown for the moment, there are not so serious adverse effects following in immunization with HPV. Did I answer your question, Dr. Navid?
Yeah, thank you very much. Actually, this is one of the major cause of vaccine hesitancy globally. So I think you have to take account of this AFIs for this HPV vaccine and share the analysis.
Yeah. So indeed, the vaccination hesitancy around the world is a serious problem for us as public health people. We know that the common vaccines we are using are one of the best things you can do in medicine, but especially with COVID, we have seen in different parts of the world increasing hesitancy if it comes to vaccines, and this is broad. Any kind of vaccines. So it's good you mention this, and I think we have to deal with it in all the places where we are, because we also have to enter the discussion about vaccine in general and the adverse effects that a vaccination can have. Well, thank you very much for raising this point. And I'm going.
Bettina, can I add something just
Please,
something
go.
to that? I think also the issue is exacerbated with HPV in terms of thinking about potential adverse effects because of the association with fertility and sexuality. So there are lay beliefs around or fears rather around the impact on fertility of HPV. Unfounded, of course, but nevertheless, these things add to, in particular social media world, add to vaccine hesitancy around HPV vaccination. So there's definitely a link between that reproduction and fear, vaccine fear.
Yes. Oh, yeah. This is an add-on reason for HPV, fertility rate, sexuality. Thank you very much. And Dr. Nair, good for raising the question of and the topic of vaccine hesitancy. I have on my list here Spectateur Anonyme, who was already early on there. He asks, what approach, or would you like to come in yourself, Spectateur Anonyme, or do you want to be anonymous? Then I read out your question. So, Anonyme, what approach to gender neutral or gender positive HPV vaccination would you recommend taking in low resource settings which are struggling to achieve sufficient coverage of HPV vaccination in girls? We know that it is far more impactful and cost-effective vaccinating girls than boys when you consider the greater burden of HPV-associated disease in women. However, when considering limited resources and patriarchal belief systems that exist in many countries, there is a real risk of limited HPV vaccination resources, which are currently focused towards girls, being redirected towards boys, and vaccination in boys instead being prioritized to the detriment of girls. Wow, I think this is a gender question. Claire, would you enter there? If we give them boys, then they will get it all?
Yeah, I think this is a very justified question to ask in terms of allocation of resources in patriarchal societies. I think I mean there's several different ways to respond to that question. One being, if we think about the global goals, the SDG goals, we're trying to attain health for all. We're trying to have an equity-based approach to health for all and leave no one behind. And if we couple that with a longer-term ambition for HPV, in terms of, as you said earlier, Bettina, in terms of eradication, this is a vaccine-preventable disease. We would like to take, I think we should take a global long-term approach to this, which seeks to eradicate. And in order to achieve both those two global goals, we do need to be covering everybody. Everybody needs to be accessing the vaccine, and that it should be built into sort of the programs of childhood vaccinations. That would be an approach that would achieve those longer stretch goals that we would like to see as public health and global health actors. In terms of the risk of a prioritization to the detriment of girls, I mean, the allocation of resources is something that is a policy level decision. And I think, and also someone else mentioned about, is this a financial decision? And again, that's a policy-led political decision on the allocation of obviously, scarce health resources. But it depends on where we want to set those goals. But I think you make an important point in terms of the patriarchal belief systems that have certain ways of dividing up resources, and we should always be mindful and attentive to the diversion of resources and use a gender analysis to track and map them in order to ensure maximum benefits to all. Thank you.
Yeah, thank you, Claire, and thank you for putting in this balance between boys and girls, and in especially restricted systems with a patriarchal system behind. I see that Scott Anthony Martin has 2 other questions. Would you like to come in live, Scott Anthony Martin? You're kindly invited to ask your questions directly, if you wish. No? No wish to be there? There is someone raising its hand, her hand, his hand. Maria, someone's coming in? Oh, Dominique is coming in. And Demilade Osote. Also, before I answer the 2 questions of Scott Martin, I would like to have Demilade Osote, please ask your question, and then followed by Dominique Konji. Demilade, would you like to ask your question or to present your story?
Well, thanks. I think I have a question to ask. Can you hear me?
Yes. What?
Yeah, yes, great. So I think the points you make are very interesting points, and I think one of the other ways to strengthen the argument is to emphasize how quickly we can eliminate or eradicate cervical cancer if we vaccinated both boys and girls relative to vaccinating just girls. And I think for policymakers who may be interested in elimination, that would be a very compelling story to them. And I give an example. I think we had not done the analysis for boys and girls, but we've done a preliminary analysis for girls only vaccination, plus the testing, plus the access to treatment. And what we saw using the elimination planning tool from the University of, from the Daffodil Center, and what we saw was that for Nigeria, it will take, elimination would be achieved sometimes in 2070, which is a really long time. Now, policymakers are very short-sighted. Nobody wants to invest in something that will eventually come to an end in 2070, where they would not be able to claim some responsibility for the success. So as we engage with lower income countries with these kinds of information is to say, what if we vaccinated both boys and girls? Can that shorten the timeline for achieving elimination? What is the cost effectiveness of vaccinating boys and girls rather than just girls? And that could be strong points to make that. Yes, it might be additional investment in procurement of vaccines, but this is the potential benefits. I mean cost benefit, not cost effectiveness. This is the potential benefits that would have over the current method, the savings in money, the savings in time, the savings to the health system. I think those are some of the other arguments you could use to strengthen the case for vaccination expanding to both boys and girls. Thank you.
Thank you very much. And please, perhaps you could just tell you from where, who you are and from where you are talking to us. That would be nice. I understood you. That would be good for the audience to know.
Yeah, thank you very much. So my name is Demilade Oshoteku. I'm a principal with Solina Health, which is a Nigerian entity supporting the rollout of HPV vaccination in Nigeria. Thank you very much.
Thank you very much for this voice from Nigeria. And I say directly to Dominique Konji, who comes in from Cameroon. Dominique, voice is yours.
Thank you. Thank you, Bettina. Thank you, Claire. I'm Dominique Konji, the president of Cameroon Public Health Association and the director of the NGO Building Capacities for Better Health in Africa. Well, it's very interesting what you are presenting, and I think my concern is about communication, how we communicate, how we make sure people understand what is HPV vaccine and what is HPV infections. We talk a lot in our countries about cancer, and when we say cervical cancer, we see women, we don't see men. And we talk less about HPV infection, because HPV infection affects men and women. I'm talking about communication. The way we communicate in our countries on vaccination in general, and HPV vaccine in particular, is top-down. It's vertical. It's somehow, I think, dictatorial, if I can say that. It means when we decide to propose this vaccination to the population, we don't consult the population. We don't discuss with stakeholders. We don't discuss. We don't share it with them to explain why this vaccination, why, to explain the epidemiology, because by explaining the epidemiology, they will understand that women and men can be affected, and they can understand why we propose gender-neutral vaccination. So I think we need to insist on communication, on advocacy, and behavior change communication. I think this is what I wanted to add. Thank you very much.
Thank you, Dr. Konji. That I think you raised an important part about the communication ways and how successful it is to have, for example, peer groups communication that have been practiced in schools in several countries, that you create the peer-to-peer communication and they among themselves talk about and decide also by themselves, because we come, as Claire already said, Claire perhaps, we are in an age group where these are no longer children, but we could call them young adults. They have their way of deciding. It's the parents, and it is their communication that may be sometimes quite different from the language their parents and governments use. So I think, Dominique, this is a very, very important point. Thank you so much for raising it, but also thank you for the presentation or the question from Dr. Osote. I see in the questions that came up here in the list, Scott Anthony Martin. He has a very tricky question. To what degree is the mortality rate of HPV in men masked by men having lower life expectancy? The other things kill us first, so it is misleading perhaps. Thank you. I think that should be a good epidemiological study of comparing how much of HPV mortality in men is disappearing because the men die earlier than women. It's a very tricky one, but I'm not aware of a study for that. And we also have Scott Anthony Martin asking, in developing nations, the mortality from HPV is clearly higher than in wealthier nations. But has religion been factored into this, not just GDP? I know religious friends who would decline intimate screening, for example. Could this be a factor in some parts of the world? I would like to turn to Claire for this question of religious beliefs. Claire, what would you say to Scott Anthony Martin?
Thank you for the question, a really important one. Social, cultural, religious beliefs certainly do play a factor in accessing preventative interventions such as a pap smear, which is an intimate investigation. So certainly that there are ensuring that perhaps there are women doctors available in which isn't always possible in service provision for these types of investigations is one way of trying to facilitate a greater uptake among women in participating in a pap smear type intervention. To what extent it is more or less, I think in your question you say related, I think it would be too difficult to isolate it as a factor in comparison to GDP. But I think clearly the developing nations, as you say, or low income, low resource nations where the mortality is higher is clearly a combination of factors, a lot to do with the health system and whether the health system is actually even engaging in the screening, and then when finding positive cases, to what extent they can engage in treatments and how quickly. Obviously, this is very a time sensitive process in treatment. So I think ultimately it's a combination of factors, of which social, cultural, religious factors are certainly can be a barrier to engaging women and girls in screening testing. Mm-hmm. Thank you.
Thank you, Claire. I have seen here several questions and comments coming in from Sonia Bota. Are you there, Sonia? Would you like to perhaps come in yourself? Raise your hand and we let you in so that you can ask your questions and make your comments or also your experiences. Yeah, there you are. Please come in. Sonia.
Can you hear me?
Yes, we can.
It is still morning in South Africa. The misty, rainy day today and quite cold for Cape Town. My inputs were more comments on your presentation. Thank you for receiving new information. I didn't know about Eva Peron. So firstly, I shared a link in the chat, which is an excellent resource on immunization. And there's videos as well, sharing information on how to get men to attend your facilities. How do you reach out wellness and health-seeking behavior to men, which I found very helpful. And then in South Africa, we launched the HPV vaccine initially to grade 4 girls, understanding that they will turn 9 in grade 4, but consequently we switched to grade 5 because we realized a lot of the girls, and this was rolled out in a campaign format twice a year. So we realized that some of the girls would only have their birthday after the second campaign, so they missed out on these vaccines. We did not provide catch-up. So in 2020, we switched from grade 4 to grade 5 to afford more girls the opportunity to get the vaccine. We were using the 2-dose schedule of the Cervarix vaccine, which provides protection against strain 16 and 18, especially focusing on the more causative virus of cervical cancer. But as of 2024, we will be switching to a single dose schedule for girls who's not immune compromised. And we will continue with 2 annual campaigns per year. The focus will expand to include girls in private schools as well. But the decision is based on resources and financial viability. Hopefully we can start doing catch-up and screening of the older girls and then providing the vaccine to the older girls as well. We are it's in the process that we are planning a mother-daughter campaign where the mothers will be screened for HPV, and then if they test negative, they can then also receive the vaccine. We are looking at up to 30 years of age. So there's a lot of exciting changes happening in South Africa, and I'm very glad to for the Western Cape province, be the lead on the HPV campaigns. Thank you.
Thank you. Could you please quickly introduce yourself? We know you're from South Africa, but perhaps some words about you so that the audience knows you better.
Apologies for that. I am Sonia Botha. I am a Deputy Director for Clinical Policy and Governance in the province of Western Cape, which is in South Africa.
Thank you very much. Was there something, I heard a voice from Dominique Konji, or no, then it's fine. Thank you very much, Sonia. And the experience from South Africa, which is hands-on experience, raises 2 points. You raised the point about the decisions of age for girls and also about the financial decisions that clearly determine the campaign. And you also said one word, immune system and immune competent. And Sonia, I would like to see with Manjit Kaur. I don't know if he wants to come in, but I see the question he or she raises. Manjit Kaur, do you want to come in? If not, I think it's a question that also fits well to South Africa, Sonia. How can we, the question from Manjit Kaur is, how can the intersection between HPV and HIV be leveraged to support for HPV? How can learnings and best practices from HIV be used for activities such as info and awareness? Who wants to take up on that? I would have thought of South Africa right away, but perhaps I turn to Claire, our knowledge that we gained with HIV.
Okay, thank you. So I think by way of response to that question, I'm going to cite some of the work I've done on HIV in Malawi, in fact, where we've been working on HIV mother-to-child transmission, and and engaging men and boys actively in supporting of mothers in attending to clinics. And quite interesting, and I mentioned earlier in my slides about having men's health clinics. That was one of the ways in which we've engaged men and boys in HIV prevention. So I think, yes, there is certainly, if that's an example, ways of learning from HIV in terms of how to communicate and tailoring our health systems to be more accommodating and easier to access, depending on the various different factors, not just your gender, but also the social economic factors, your distance to travel to a clinic, and the ways in which we communicate about HPV. Certainly, I think a huge amount to be learnt in supporting HPV prevention programs or cancer prevention programs. Indeed, yeah, absolutely.
Thank you, Claire. And if I may add to this, I think that the HIV movement, let's call it this, has still a lot of learnings for us, also in terms of advocacy and asking for the right treatments, because there's no vaccination for HIV, but the HIV movement and AIDS movement really succeeded in advocating, I think. And the strength of advocating is something that could be a learning for human papillomavirus as well. I would call the HIV advocacy a very successful one, and I would see as much successful advocacy also into HPV. So I hope that for Manjit Kaur, that was a sufficient answer to the question. And I will go. Yeah.
Sorry, I was going to add to that, because I think that's such an important point about what we can learn from HIV activists. And also, if we think about the governing bodies of organizations that have come out of HIV campaigning, and the fact that the stakeholders who are involved in the governance of those organizations are also patients. So I think in terms of, people who have survived cervical cancer, bringing them into the campaigns and showing ways forward would also be ways that we can learn from the successes of HIV activism, certainly.
Yes, indeed. Thank you so much, Claire. And this would come back to Dominique Congi's comment on communication. The way how the communication went on in AIDS advocacy was really something which is still a learning, yeah. And also there is someone who wanted to speak. Karim, please come in. I haven't seen that. Sorry. Karim wanted to come in. Please. Yeah, Karim comes in, I think, from Tunisia, but introduce yourself, Karim.
Yeah. Do you hear me? Okay.
Yes.
So I'm Karim Abdulwahid, president of Tunisian Association for Health Promotion, and I feel good with this problematic. So I have an idea about.
You have two devices
vaccination.
on, and there's an echo. If you could put one device off, I think then we have less echo.
Okay.
Yep.
Thank you. It's good now.
Yes, perfect.
Okay, thank you. So I will talk about vaccination, because we have suffered about vaccination, especially in 2021. But the Tunisian Association for Health Promotion, our Tunisian Association, have a good solution for this problem. So we remember that our Tunisian Association for Health Promotion managed to save the serious situation in Tunisia in 2021 by organizing the mass vaccination days with one shot for 3 million doses. So we have made a good plan, a simulation play, like elect days. We have introduced the same database for the vaccination in COVID-19, because we have no solution in this moment. So our association have this plan with the presidents of Tunisian Republic, and we have solved this problem. But after that, I think that the problem of vaccination is to restore the mental health of the population, because the shocks and of COVID-19, people suffer from the loss of their family and friends. Now vaccination represents a phobia, a seriously phobia, especially with young people, and international awareness plan is mandatory to resolve this problem. In this way, I ask to make a big and whole plan for mental health, to restore the confidence for people, especially with young people. Young people, they don't like now to vaccinate any kinds of vaccination, you know. So this is a serious point to solve, and we ask with our federation to go ahead with in this way. Thank you.
Yeah. Thank you. Merci, Karim from Tunisia. Also with the question about vaccine hesitancy and the fact that particularly young people have no more confidence in whatever vaccination at all, and also underlying the importance of the general mental health setting of a whole population that may influence the positive or negative attitudes to vaccinations. It's very important, and I think worldwide important argument to look at. There is a link between mental health of a whole population and the vaccine hesitancy. I see here from Nigeria someone, Timbiere Sabenos from Nigeria, or from somewhere, I don't know. Do you want to come in, Timibiere Sabemus? Would you like to ask your question yourself? You're cordially invited to raise your hand and to come in. If not, I'm going to read out the question myself. Ah, he comes, or she, I don't know. Yes, please.
Okay, please confirm you can hear me.
Yes, we can hear you very fine. Please.
Okay, good morning, everyone. My name is Timibere Sabinus from Nigeria. I work with Corona Management Systems, and we supported the launch of the vaccine, of the HPV vaccine here in Bayelsa State, the southern part of Nigeria. So I would like to know, how can we resolve the issue of high mortality rates with the low vaccination rates following gender-based vaccination campaigns, especially in low-income countries like my country, Nigeria?
Thank you very much. Very, very serious and important question. Yes, as I said, it is appalling to see what mortality rates there are. And for sure, the whole healthcare system comes into play when you talk about mortality, because it's also the treatment side. But you say that you have low vaccination rates. Do you have some vision about how much the coverage in Nigeria is for the moment, because as we have seen, the vaccination is a real means of eliminating HPV. And as I see you seem to be into the topic very much. Do you have a rough estimate of the HPV vaccination coverage in Nigeria?
Okay, so cumulatively for Nigeria, I don't have that offhand. But for Bayelsa states where we implemented, we had I would say we had a good coverage for Bayelsa. That was the first launch. We had about 93% coverage for the first launch of the vaccine. However, like I said, it's a gender-based vaccination campaign, which has to do it was just basically for the girl child between 9 to 14. But we have young boys. We have young boys within these ages that were eager to get these vaccines, but due to the low availability of the availability of the vaccines, the low number of vaccines we have at the state, we couldn't get across to these boys that were eager to get the vaccine. And knowing fully well that these boys are carriers. So in as much as we are trying to get girls vaccinated to prevent them from getting HPV. From the southern part where I'm from, or where I'm speaking from, we have these young girls getting active and getting very active sexually at a very early age. So how do we now reduce the mortality rate if we're just vaccinating the girls and the boys don't get these vaccines?
Yes. Yeah. Thank you so much. And you even told about boys being willing to take up the vaccine, but you are restricted. And this is a question that came up in a lot of the comments that I can see here. The question about, is money the issue, or are there any ways to circumvent the problem? And I have someone else coming in here from Egypt, Mona Samir. She makes the argument for vaccinating girls. Mona, do you want to come in directly? I've seen your question here written, but you can come in and ask yourself and contribute to the discussion. Mona Samir. Yeah. Oh, there you are. Welcome.
Hello everyone. My name is Mona. I am the project manager of United to End Cervical Cancer in Egypt. Our program is for spreading awareness for HPV infection and the importance of the vaccination and spreading awareness about the dangers of cervical cancer. And we do also screening for women, and we do vaccination, but only for girls. As I mentioned, due to the high cost of the vaccine, which make it accessible in our countries, wouldn't be more logic to vaccine girls to gain cross immunity, so we can reach wider impact or protection?
Mm-hmm. So from Egypt and from your association United to End Cervical Cancer in Egypt, you would favor to start with girls first. That's interesting. Thank you for this. And I've seen that Adriana wanted to come in. Please, Adriana.
Hello. I guess I maybe have a somewhat similar question. I think I understand the potential benefits of.
Introduce yourself quickly, just who you are.
Hi, my name is Adriana. I'm working at a US-based NGO on immunization. So I understand the potential benefit, of course, of vaccinating both boys and girls, but I think for me, I'm not sure, what you would suggest to be able to overcome the very real challenges of resource constraints. So, for example, many low and middle income countries are entirely dependent on Gavi to fund vaccine doses. So, in turn, Gavi is limited both by, the global fiscal space, as well as there has been ongoing prolonged issues with vaccine supply at a global level, at the level of vaccine manufacturing. So, the reality is that we have to deliver a program within constraints that we have, right? So I guess my question would be is, what do you suggest to address some of these very real constraints and some of the trade-offs that, country programs are making every day? Thank you.
Yeah, thank you, Adriana, for coming to the questions that are also in the chat a lot. The question about resource restriction, if I can come just quickly on that, I think a lot about what AIDS was. The arguments were the same. The treatments are too expensive for the countries where the burden is high. But if someone tells me the resources are restricted, money is restricted, let's say money, then it is a little bit like with time. If I say I have no time, it means I put my time to other things. If I say I don't have money for life-saving vaccine, that I put it to something else. And it is true that it is always a trade-off, as you said, but we have to question ourselves where we have the most value for our resources, and being, logic about boys and girls, the reservoir, the transmission, and the fact that we will be faster if we vaccinate both sexes. It is worthwhile to consider where the resources are best invested, I would say. This would need perhaps a health economist to do a quick analysis, but it is definitely in all resource constrained, and at the end we are all resource constrained, a population and political decision where we prioritize. And so I think you clearly say, we see it with WHO and Gavi. They say if there is no money, we go for this. But for me would be the question, why is there no money, and why do we put money in other things? Where is our value system? That's the question above the fact that there are resource constrained places. I do see, did I oversee someone, or Ariana, is this for you a way of entering the discussion of saying resource restriction is also a decision at a political level?
Yes, absolutely. I think you make a great point. But I think then it might be a bit of a slippery slope, because then you may get into, kind of comparing, maybe that kind of conversation could lead to perhaps even less funding for HPV if all of a sudden there is more interest around, for example, measles, which has a quite high mortality rate, right? So, yeah, I think I hear your point. I think it's a difficult conversation to have.
Yeah, yes, and you mentioned the next disease. I think we as public health people and also as policymakers should never make trade-offs between different diseases. That's a very dangerous thing, to value this one versus with this one. We have to think in systems and get all people concerned under our umbrella. Yeah. Is there anyone who would like to comment on the resource restriction and the question of, while there is resource constriction, we only go for girls? Or if not, I would like to read out a comment. We had Dr. Navid, who was in live at the beginning. He has a comment for combating HPV vaccine hesitancy. He says we can adopt integrated approach, integrating HPV into routine immunization protocols. RCCE. Third, extended outreach in high-risk areas. 4, strengthen AEFI system, so adverse event. 5th, integrating HPV in static and outreach immunization camps. And 6, dedicated mass vaccination campaigns. So thank you, Dr. Navid. You gave us a full program of things we could do to get to overcome the vaccine hesitancy. I think at least 1 or 2 of your proposals are very, very interesting for places, and why not have HPV part of routine immunization protocols where they exist would be a question to be put to policymakers and public health concerns. I run through my my list of Q&As here. I hope I haven't missed someone. I have seen a very nice message from Dr. Mukund Lal, who said that's very nice World Federation for HPV immunization, and he thanks us. Thank you for giving us this positive feedback. Do I see because it's difficult for me, do I see a hand that is raised that I have missed for the moment? No. So we are coming close. Dr. Navid, you have raised your hand. Is it still an old raised hand, or is it from the one we already answered? I think it's the one.
Yeah, it was for the previous comment. Actually, I am in traveling, so unstable data connection. That's why I wrote in the chat box.
Okay, thank you very much. I mean, what we have in the chat box is a work for 2 years for the next all public health people, but I like very much your proposals. Thank you very much.
Thank you. Thank you.
I would like to turn to my friend and colleague, Claire. What is we are coming to the end of these 2 hours. What would be your messages at the end of our discussion? And I would like to thank all the discussants from all around the world for their participation and their very valuable inputs. And I turn to Claire. What would be your main impressions from today?
Yeah, thank you, Bettina. Thank you, everybody, to participating. I really enjoyed listening to some of the interventions and comments. I've definitely learned a lot myself. I think in terms of a gender strategy to HPV and the possibility of vaccination, it really depends somewhat on the goal and the objective. If we're looking longer term and with limited resources, then your gender strategy would be different to that which you would be thinking about if it was very short term and you are looking for whether or not you're looking for eradication. Clearly, we cannot have eradication without vaccinating everybody. That's not going to happen. So I think a lot of our gender strategy energies might want to be put into lobbying and advocacy, and also campaigning for reduction in the price of the vaccine as well. And it's a multi-pronged, it's a multi-sectoral approach. And I think that we can do various different gender strategies to achieve the different goals we have over a timeline. I'm very encouraged from one of the speakers today who said that boys were eager to be vaccinated. So I think that's the most encouraging message to take away, that that communication is effective somewhere. But I thank you everybody for participating, and really have learned an awful lot. And thank you, Bettina, for inviting me to offer a few comments today.
Thank you, Claire. And I would like to turn to our important end and say what is all at stake. We, as you know, are running a series of webinars. I have had the honor to start this series of webinars, but it is only one start, and all those who helped us to start really are thanked. The next will be on the 24th of June, and then we will have a webinar in September 2nd and in September 25th. We had today a great participation from African countries, and I would like to underline very much the participation of Dr. Dominique Konji. Welcome, Dr. Konji, because you know we are trying to go around the world and we will use different languages. And the next webinar on 24th of June will be for the French-speaking African countries, pour l'Afrique francophone. And Dr. Konji will be one of the main people in this webinar. So for all of those who are French-speaking, and particularly French-speaking Africa, this will be the place to discuss HPV vaccination, gender-neutral HPV vaccination in your language and around your countries. So it is a very, very, very good moment for me to say thank you. Thank you to Claire to come in with her views on gender and all her knowledge about gender in health. It is thank you to say for the ones who were preparing the webinar behind the scenes. And most importantly, I have to thank all our sponsors, which is very much my university, the Université de Genève, University of Geneva, and also MSD for the charitable donation that we received to run such a series of webinars that I think need to continue. As we have seen today, we have seen that everyone brings in another aspect, and that probably, especially in the advocating and communicating part, we have to still do a lot of things. My thanks to all of you online, my thanks to our sponsors, and especially those who have been so patient to sit on with us for almost 2 hours. Grateful to have been with you, and I hope you can take some parts of the discussion further to your country, to your policymakers, and to people who will decide or not. Thank you so much. Thank you to everyone. Thank you for being there.